Thank you everyone for sticking out to the end, and bonus points if any of you have an eagle eye and notice the slight difference in my talk, the title of my talk, qualitative findings. It was findings, it just says findings in the agenda, but that emphasizes the qualitative findings from our trial, in case any of you were eagerly awaiting the RCT findings, which are not quite ready for prime time, although very soon. So first I want to acknowledge and thank the funding by HSR&D for the study, and also want to acknowledge and note the involvement of Correctional Counseling Incorporated, who are the developers of MRT and provide the training for MRT to our study staff, and we're paid consultants in the RCT. So I think many of you may know that in the last 10 years or even more, there's been a policy shift in terms of corrections in this country, a shift largely from incarceration to diversion. So a move to get more adults, justice for all adults. Just waiting for the next screen to pop up. Well, as that hopefully pops up soon, I'll note that, again, policy shift in this country, getting more adults involved in the criminal justice system out of jails and prisons and diverted into treatment services. And kind of consistent with this, the VA, there we go. There's been a lot of upsurge in veterans treatment courts nationally in the last decade, as well as the emergence over the last 12 years of the veterans justice programs in the VA. So more veterans have been coming from the correctional system into the VA services for the last 10 years, and consequently, VA mental health services is now increasingly being asked to address and treat justice for all veterans and reduce their risk of recidivism. So this begs the question of what are best practices for reducing recidivism risk. In the offender rehabilitation literature, overwhelmingly the consensus is that cognitive behavioral treatments are best practices for reducing recidivism. But in particular, cognitive behavioral treatments that are very structured, manualized, and in particular that focus on trying to modify or restructure what's referred to as criminogenic thinking. So what is that? It's kind of a fancy way of basically saying kind of a criminal mentality or thought process, automatic thoughts and behaviors and patterns of behavior that get one involved in the criminal justice system, things that sort of focus on very impulsive behavior, thinking in the moment, not thinking long-term, sort of thinking more about other people as being against you rather than potentially helping you, sort of almost like a personality pattern that gets one sort of wrapped up in the cycle of criminal behavior and substance abuse. So that's noteworthy in the fact that in the criminal justice literature, criminogenic thinking is regarded as one of the most robust risk factors of recidivism, particularly modifiable risk factors. Now, arguably one of the best interventions with the most evidence or support to reduce criminogenic thinking is moral recognition therapy, or MRT. And that's not a typo, it actually is moral recognition therapy, not recognition. It's an unusual term, and I won't go into the origins of it in case someone's curious in the Q&A. But in short, MRT is an intervention that tries to target criminogenic thinking. It's manualized cognitive behavioral intervention, and it uses a group format and also an open enrollment format to its intervention. So as people come into the group, there's oftentimes people who have been in the group for a while and have proceeded along higher levels of moral development or higher steps in the intervention, and can serve as sort of mentors to people who are newly entering the group. So the strong peer facilitation, peer support component to these groups. Essentially how it works is patients or individuals are enrolled in MRT, they're handed a workbook, and there's a series of exercises and homework assignments for each of the 12 steps of moral development that people are asked to proceed through. And in between group sessions, people do the homework assignments, hopefully, and then they come back during the group sessions and present their work just in support of trying to complete a certain step of moral development. And the idea is to complete 12 steps of moral development in order to hopefully change the way you think about things and hopefully change your risk of recidivism. So that's kind of the gist of MRT, and it doesn't take, or one group session isn't going to get you past each step. It takes on average, at least per the developers, about 2 to 3 sessions on average to complete one step. So you have 12 steps, means that it completes or takes about on average 24 to 36 sessions to complete MRT. So it's not trivial. But MRT, it's important to note, that was developed for correctional settings where you literally have a captive audience and strong external incentives for someone to take part and complete the intervention. However, the VA has been very interested in MRT for a number of years now and have been expanding its implementation within many of its mental health services. And this has been driven largely by our operational partners in the Veterans Justice programs, who worked and collaborated with the developers at MRT, Correctional Counseling Incorporated, to create an MRT workbook for veterans called Winning the Invisible War. And it actually has a pretty large footprint in the VA now. I think based on some work we've been looking into, work we've been doing, approximately 50 VA medical centers have active MRT groups going on. But there hasn't been a lot of evidence or research yet to establish what the evidence base is for veterans, in particular to really understand how does the implementation of MRT work within a non-correctional setting like the VA. So that was really the focus of this study. So our objective broadly was to implement and evaluate MRT as an intervention to reduce recidivism and improve associated health outcomes for justice-involved veterans. And we did this as part of a hybrid effectiveness implementation trial. It's a hybrid 1 trial. So the RCT component, of course, and then a second part, a process evaluation to better understand issues of implementation of the intervention. And I just highlighted process evaluation again to emphasize that the RCT results are not yet available, so I'll focus on the qualitative findings today. This was conducted at 3 sites, and the settings that we implemented MRT into are domiciliary programs, or DOMS. So for those of you who aren't familiar with DOMS in the VA, they're longer-term mental health residential programs, typically ranging from 3 to 6 months to address the mental health, substance use needs of veterans, and oftentimes also veterans who are struggling with housing issues, employment issues. And we were interested in implementing MRT in those settings, partly because, again, being longer-term programs and MRT being so intensive, we wanted a setting where patients would be there for a long time and get more exposed to MRT. But also from some of our own research as well as other research, we know that a high proportion, in fact, probably the majority of veterans in domiciliary programs have fairly extensive histories of being in and out of jails and prisons. So we felt this is a population that may be in great need of something like MRT. The basic design, 2 conditions, usual care in the DOM or usual care plus 2 groups of MRT per week for 12 weeks. So potentially trying to give them that dose of 24 sessions if possible. But of course, understanding that 24 sessions is a lot to ask for anybody in a residential program. So our target dose, and talking with the MRT developers, was to try to get a minimum dose of 12 groups that participants who are randomized MRT could engage in. Several inclusion criteria. The one here I'll note, though, is that we try to enroll or recruit veterans who were in these programs that were arrested and charged and or incarcerated in the past 5 years. Took a fairly liberal approach to inclusion. And enrolled 344 in the RCT, half of whom were randomized to the MRT condition. Now, again, the RCT results aren't yet available, but of course the RCT itself is done, so we do know kind of the level of engagement of the veterans that were enrolled in the study in MRT. 12 groups being the target, approximately 1/4 of participants who were randomized to MRT attended actually 12 groups, which certainly on the lower end, although roughly on par with many other behavioral interventions for mental health issues. Unfortunately, 1/5 of participants who were randomized to MRT never went to any sessions at all, so there were some who signed up for it, randomized, but ultimately got too involved, as I'll say more later on, got too involved in other residential activities to be able to participate. And the mean number of groups attended among all those randomized was 5, and among those who at least went to one session was 7. So engagement was really the albatross of this study and something we wanted to understand, particularly during our qualitative process evaluation. So that's kind of how the process evaluation was largely structured, was to understand the issue of patient engagement. 36 interviews with the patients, 12 per site, and again, tried to sample patients from a range of different levels of engagement. The numbers in parentheses indicate the range of groups that the range in terms of number of groups that participants in those levels of engagement attended. And that's also not a typo there, 168 groups. One of our participants was randomized really early on, loved MRT so much that he came to every single 2 groups per week, and even after he completed MRT and after he completed the residential program, would come back on a bus twice a week to the MRT groups to serve as a mentor for other veterans. So he was a big champion, nonetheless. So that was, there's quite a range in terms of level of engagement. In addition to patient interviews, 13 interviews with domiciliary staff were involved in implementation, 9 of whom actually facilitated the groups in those settings, and the rest who were administrators and kind of helped with the implementation at the beginning of the study. I'll just briefly go over this. I won't go into too much detail, but the interview guides that we used were guided by the REAIM framework. And we cover all the REAIM domains, but focused largely on reach, adoption, and maintenance. And again, because patient engagement was low, we focused questions around the reach domain, largely trying to get information on understanding patient engagement. So let me get right to the results here. So in terms of the first barrier that we identified that was related to a barrier to patient engagement, not surprisingly, the length and time intensity of the curriculum was the biggest thing that both patients and staff noted. So many patients who didn't stay engaged in MRT, and some even who did stay engaged, noted that the workload was quite overwhelming and really highlighted the fact that they had a lot of competing demands in their time in the residential program. And it indicated all the other groups they had to go to that were required for them to stay in the program, and trying to add MRT on top of that wasn't just one other group, it was a whole other program in and of itself. And they had to address those as well as other needs like finding housing and finding a job. Just one exemplar quote from a patient who was identified as a low engager. So he indicated that MRT could be a program that runs on its own because there's a lot of work involved. The only reason I dropped out was because of the workload. Juggling the residential program and MRT was simply too much. All right, moving on. Patient engagement, a theme that facilitated patient engagement, or at least the staff and patients both indicated was helpful, or would be helpful, is that external incentives are important, and that they indicated that longer term implementation, court-related incentives and sanctions would probably be very important, as well as having peer testimonials from graduates trying to encourage veterans to participate in the groups. But uniformly, they all indicated that this is necessary but not sufficient. They said that one thing that MRT lacks is a motivational interviewing component, or something that helps people to really explore the internal kind of internal motivation. So one quote from a staff member indicated that I don't think MRT has a part built in like that. It would be interesting if there were added motivational pieces that help people kind of gauge where are they, what benefit do they see. Something that facilitates adoption, many people mentioned, is that they felt MRT actually complemented the residential programming very well. This is a big question I had going into this. Would staff sort of believe that MRT is anything unique to what they're already doing? But uniformly, staff as well as patients felt like not only is this complementing what we're already doing because it has CBT principles, peer support principles, but it has unique added value and fills a niche in our program to address criminal thinking and the justice small population. As one staff psychologist said, MRT is one of the unique groups where it can isolate personal responsibility and focus on behavioral choices and decisions that veterans are making that have gotten them in trouble with the criminal justice system. Another facilitator of adoption, many of the staff mentioned that they felt that there's a lot of benefits from MRT that go beyond recidivism that aren't readily apparent to the staff as well as the patients, that it improves interpersonal relationships, helps people be better at planning and goal setting. And two staff even mentioned they felt it was very much like whole health coaching in a way. They felt that to help facilitate adoption by other sites, it's really important to promote the benefits of MRT-bound recidivism, generate more staff buy-in and patient engagement. And also consequently, many staff felt that this is something that shouldn't just be for justice-involved veterans. Really, any of the veterans in the registered programs could benefit from MRT curriculum. And this is one quote from a patient. Not everybody's been to jail, but that doesn't mean that most of us haven't gone that low. They just didn't get caught. I firmly believe this is something that everybody here can benefit from. A facilitator of adoption and maintenance. Establishing a broad network of collaborators is something that many staff mentioned, not just within the programs and other VA services, but also many felt that establishing relationships or collaborations outside the VA for something like this would be very important. Particularly, many highlighted the fact of establishing collaborations with veteran treatment courts, the veteran justice outreach specialists at their facility to help increase both external incentives and better continuity of care. And for the sake of time, I'll skip reading this quote here and get to a couple of the barriers from adoption and maintenance. Now, MRT being highly manualized and structured, it's also, many of the staff felt that's fairly rigid in terms of how the way it's formatted and the way patients are asked to go through the steps. So very rigid rules to step completion that some staff kind of balked at and some patients as well. MRT is also very structured to be an in-person thing where facilitators can review patients' workbooks, see if they've done it correctly. So it's not exactly conducive, at least at this point, to telehealth. And also many staff felt that because it's a group, structured as a group, in a group format, that there's not a lot of opportunities built into it to do more one-on-one sessions and individual attention to patients who need that support. So one staff member here, I won't read the quote, but it felt that MRT really has to have more study groups involved here, more one-on-one opportunities to get patients a little bit help to get through the curriculum. And last maintenance barrier to maintenance or long-term implementation is that there are many costs required to implementation of MRT or adoption. This is largely driven by the fact that MRT is copyrighted by Correctional Counseling Incorporated, so there's costs for buying the workbooks for each patient, there's costs for training, of course, and having more than one facilitator being pretty critical, most of the staff felt. So I think I'm going to shorten time, so I'll go right to the last slide here. So just to summarize, again, patient engagement was a big challenge in the study, but many staff again felt that if you can add a motivational intervening component to MRT and have partnerships with veteran treatment courts to boost those external incentives, that can really help address the issue of patient engagement. We're pleased to see that there's many themes related to facilitation of adoption by the VA mental health programs. So the fact that many facilitators or staff in these programs felt that MRT really complements well what the residential programs are doing, and that adds something unique, bodes well for the likelihood that other VA mental health programs may take this up if it's indeed effective. But even if you address the issue of trying to get sites to adopt it and get patients to engage, there's the issue then about how do you exactly implement it? Do you organize care around it, because MRT is such a large program in and of itself, which is maybe not realistic, or more likely maybe to need to be streamlined and the content need to be adapted somehow. There's no brief version of MRT at this point, but it's pretty clear from our findings we feel that MRT probably needs to be streamlined and abbreviated in some form. And of course, the future steps we take will be predicated on what the RCT findings indicate to us if it was effective or not. So I'll end there, and thank you for your time, and we acknowledge the involvement of many people in this project. Thank you.